Thanks for being with us today, and we hope you're enjoying the great content put together by Trio Maryland. We want to continue to recognize our event sponsors.
Welcome to an introduction of the role of medical cannabis with transplantation, a video presentation by Peak Relief, a medical cannabis dispensary in Rockville, Maryland. If you have questions following this video, please feel free to email us info@peakrelief.com. Here are a few key things to remember when utilizing medical cannabis to provide therapeutic relief for issues that you may be facing. One of the most important things to keep in mind is take your time and ask plenty of questions when meeting the staff of a medical cannabis dispensary. If you're able to meet with the dispensary's clinical director, definitely make that a priority. Curious about the endocannabinoid system you keep hearing about? Well, the endocannabinoid system is a complex cell signaling system identified in the early 1900s. The ECS is tied to many of the processes in the human body, some of which you may be pretty familiar with. As you can see, the endocannabinoid system is the key to so many functions and operations in our body. There are many opinions about medical cannabis use, and that's why before adding it to your wellness plan, it's important to speak with your healthcare provider. And if you need more information that may help you speak to your provider, let us know. We will be happy to share educational resources that may help you. Are there complications related to cannabis use for transplant patients? A small number of retrospective studies have assessed transplant outcomes in patients with active cannabis use. In summary, more data are needed to accurately evaluate the association between cannabis use and post-transplant outcome. However, based on small retrospective studies, there is no obvious signal for harm in transplant recipients. Where can I get more information about cannabis use? At Peak Relief, we strive to increase the knowledge of the general public through detailed and informative content that helps to remove the unnecessary stigma surrounding the medical cannabis industry. So head to our website and take advantage of our cannabis curriculum and additional educational resources. It details everything from the parts of the cannabis plant to the current laws governing the use of medical cannabis in Maryland, to the endocannabinoid system and even the most common routes of administration of medical cannabis. We look forward to your visit if you decide to become a medical cannabis patient. Don't hesitate to send any questions you may have our way.
Our last session of the day is post-transplant diabetes mellitus. Am I pronouncing that correctly?
Correct.
Presented by Aniket Sideh of Johns Hopkins University. Please remember you can post your questions in the Q&A tab, and we will share with the speaker after the presentation as time allows. We are excited to have Dr. Sideh with us today. He is an associate professor of medicine and pediatrics at the Johns Hopkins University School of Medicine. His research interests include bone health of cystic fibrosis patients after lung transplant and the care of emerging adults with type 1 diabetes. Welcome, Dr. Sideh.
So I should have plenty of time for questions and answers at the end. And so this is just an introduction for persons that are undergoing organ transplant. These are just the objectives there to understand, really to introduce what diabetes mellitus is, to understand that it develops when insulin secretion falls to an extent that normal glucose tolerance is not maintained, to discuss the rationale to treat diabetes and keep blood glucoses under good control, and to emphasize the importance of all four components of a treatment regimen. So first off, what does diabetes mean? I'm neither a Greek nor a Latin expert, but the word dia comes from a Greek word that means through. And so examples would be diarrhea, which means to flow through, diagonal, which is through an angle, diaspora, which means to scatter through, etc. And betes means to pass. So diabetes is something that is passing through, and what is passing through is something that is sweet. So mellitus is a Latin word that means sweet like honey. And so the definition of diabetes mellitus is that it's a group of common metabolic disorders with the shared manifestations of high blood glucose levels. We call that hyperglycemia. And there are different forms of diabetes. I'm sure everybody has heard about type 1 or type 2 diabetes, and there's post-transplant diabetes mellitus. And these occur because of an interaction between one's genetic background and the environment. So I think to understand what diabetes mellitus is, the first thing to do is understand what keeps blood glucose normal. And the short answer is that it is insulin. And insulin is secreted by the pancreas from specific cells called beta cells, and it is secreted in proportion to circulating blood glucose levels. And so the diagram on the right hopefully shows you a schematic taken from a research study where patients were brought into the hospital and fed meals, and then their glucose was measured, and that's described in red, and their insulin is in blue. And what you can see is that the blood insulin levels rise and fall in response to glucose excursions, but that there's always a little bit of background insulin production present. And so the key regulator of insulin secretion from the pancreatic beta cells is the circulating level of blood glucose. And beta cells actually sense a rise of glucose levels above 70, and that prompts these beta cells to secrete insulin. So once secreted by the pancreas, the insulin is in the bloodstream, and the question is, what does this insulin do? And so here on the left, you see the pancreas, which is located in the abdomen, kind of towards the back, sort of in the curvature of the duodenum, which is part of the small intestine. And the two main actions of insulin are that it slows glucose production by the liver. And so I think that's important to recognize. The liver has the ability to make glucose, and that's important. So when you're fasting, for example, the liver can break down stores of carbohydrates into glucose, and it actually can make glucose from what we call non-carbohydrate precursors, and those are certain amino acids and lactate primarily. The other major place of action is that it stimulates uptake of glucose into the muscle and the fat. And so the circulating glucose level is rising, say after a meal, and insulin production is stimulated. That insulin goes to muscle and fat and tells it to take the glucose out of the bloodstream and take them up. And that's why insulin is considered an anabolic hormone. It really helps build up the body. So having understood this basic physiology, you can imagine that diabetes mellitus occurs when there's an absolute or relative deficiency of insulin and blood glucose levels remain elevated. Both of those things have to occur. There are, of course, contributing factors. So one, the major factor is the progressive lack of function of the cells that make insulin, the beta cells of the pancreas that I mentioned before. But another contributing factor is resistance to the effects of insulin. So you can imagine that if the muscle and the fat and the liver are somehow resistant to the effects of insulin, then blood glucose production by the liver will not be slowed down, and blood glucose will not be taken up into the cells of the muscle or the fat, and the blood glucose will remain high. But I want to emphasize the point that resistance to insulin alone is really not sufficient to make someone have diabetes mellitus. That in the end, there has to be an absolute or relative deficiency of insulin. And although this deficiency exists upon a continuum, typically we think of people who have something called type 1 diabetes as having absolute deficiency, and most other forms of diabetes as being a relative deficiency of insulin. And so this hopefully shows for people that are sort of scientifically inclined that you can remain normal if the balance between insulin resistance and the sensitivity to insulin is maintained. So on the y-axis here is release of insulin by the beta cells, and on the x-axis is insulin sensitivity. And in green are people who are maintaining normal glucose status, blood glucose status. And that occurs over a wide range of insulin sensitivity. So there are people who are very insulin resistant, but they can make plenty of insulin, and those people do not have diabetes. But if the insulin release begins to fall, you can see that they develop something called IGT, or impaired glucose tolerance. And eventually, if it falls far enough, then they develop type 2 diabetes. So how do we diagnose diabetes? First and foremost, if the symptoms of diabetes are present, and those include excessive thirst, urination, weight loss, certain types of infections, and any glucose, a random glucose concentration in the blood, in the plasma, is greater than or equal to 200 milligram per deciliter, that alone is sufficient. Nobody has to repeat a blood test or anything. We can use that information and go ahead and start treatment. However, if there are no symptoms, then we use a fasting plasma glucose of greater than or equal to 126 milligram per deciliters, or a test called the hemoglobin A1C greater than or equal to 6.5%. What is this test? This test is measuring the percentage of glucose that is attached to hemoglobin, which is an important protein in red blood cells. And it turns out that since red blood cells turn over about every 2 to 3 months, this can give one a sense of what the average blood glucose is. And it turns out that people who have fasting plasma glucoses greater than or equal to 126, or an A1C greater than or equal to 6.5%, or a 2-hour plasma glucose after an oral glucose tolerance test greater than 200, all of those people start to have an increase in the complications of diabetes. And that's why the thresholds for diagnosis are set where they are. I want to make one word about the A1C. Since the A1C depends on normal red blood cell turnover, sometimes after transplant, it is not a fully accurate test for diagnosing diabetes. Certainly, it can give you a sense of what the average glucose control is, but it may not be accurate to diagnose diabetes. So if the person is not having any symptoms, we like to confirm the test if it's positive, just to make sure that it's not a false positive. And these criteria cannot be uniformly applied to all patient groups. There are certain patients and certain disease states where these criteria have to be tailored. Okay, so that's sort of the very basics of diabetes. So what factors are contributing during or after organ transplantation to diabetes? So first and foremost are what are called steroids, but by this we really mean glucocorticoids, and the most common one that people in the transplant setting encounter is something called prednisone or prednisolone. And these steroids have the effect of impairing the action of insulin, and that effect is particularly pronounced after food intake, and that's because the part of insulin action that it's affecting is most relevant for stimulating the uptake of blood glucose from the bloodstream and into muscle and fat after a meal. And sometimes we actually refer to this as, if somebody doesn't have diabetes beforehand, as steroid-induced diabetes mellitus. And I know I already saw in the chat there are some questions about that we can get to in a second. There are immunosuppressant medications that can cause diabetes mellitus, and I've listed 2 of them, tacrolimus and sirolimus, as examples. Tacrolimus is in the category of a class of medications called calcineurin inhibitors. So both tacrolimus and cyclosporine fall in this category, and both can contribute to the development of diabetes. It is more seen with tacrolimus than cyclosporine, but it is seen with cyclosporine as well. Sirolimus belongs to a category of medication called inhibitors of target of rapamycin, and or mTOR inhibitors, and sirolimus and everolimus are part of this group. And the bottom line is that these medications, they impair the function of beta cells of the pancreas. So they impair the ability of the body to make insulin, I'm sorry. The other contributing factor with tacrolimus in particular is because it can affect the kidneys and cause wasting of magnesium in the urine. Sometimes patients have low serum magnesium levels, and it turns out that magnesium is an important part of the insulin secretory apparatus. These medicines may also affect insulin resistance. I think that evidence is a little bit unclear, but the major factor is that these medicines are toxic to the beta cells of the pancreas. Of course, the other issue is that there's illness, inflammation, and stress, particularly in the early stages after transplant, and sometimes even leading up to a solid organ transplant. And there's increased resistance to insulin in the tissues, by which I mean muscle, fat, and liver, in this situation. And so that can be a contributory factor. I'm sure that many of you already know that that diabetes mellitus develops very commonly. Probably the best studied situation is kidney transplant patients, in which case 10 to 20% of patients may develop post-transplant diabetes mellitus. For other solid organ transplants, it appears to be around 20 to 40%. So I think it's important to know what the consequences of diabetes mellitus are. So of course, in the short term, if the glucoses are very high, because all that glucose then gets spilled in the urine, people then have excessive urination, they become very dehydrated, and if the glucose level gets high enough, this could be a risk factor for stroke. For certain patients, there could be a buildup of acid in the blood. This is usually for patients who have type 1 diabetes, or in very rare circumstances, people who have type 2 diabetes as well. And the buildup of acid in the blood is obviously very dangerous. In the medium term, there is an increased risk of cardiovascular disease and a risk of infection. So and just as an example, in kidney transplant patients, we know that there is an increased risk of cardiovascular disease, and this is increased even further with diabetes, as it is in the general population. So to some extent, it's not really any different. In the long term, know that diabetes is associated with certain complications, which many people have heard of. This is damage to the eyes, or that's called retinopathy, to the kidneys, which is called diabetic nephropathy, and to the nerves, which is called diabetic neuropathy. Those are, we call them microvascular complications, and they can develop in the setting of transplant-related diabetes as well. So I think that what we want to emphasize is that diabetes is a risk factor for these other conditions as well. I don't go into this much. There is some evidence that in certain circumstances, it may affect graft function and graft survival also. And so what is not known is whether good glucose control will improve that, but we obviously think that it certainly will be beneficial. So how best to take care of diabetes if one develops diabetes? So I like to say that the treatment of diabetes is like the four legs of a stool, and it involves monitoring one's blood glucose and to work on the output. So obviously trying to be as physically active as possible helps one burn calories. To do that, one must use glucose, and that helps lower blood glucose. But to also work on the input, which is the diet. So for somebody whose beta cells can't make enough insulin, the more glucose or the more carbohydrates we take in, that puts a higher load on the pancreas that cannot be matched. And the blood glucose will remain high and cause complications. And then finally, of course, is to take medications as prescribed. And so I like to think of this as a four-legged stool. And for those that like images, I'm not good at drawing, so I picked this from the internet. Obviously, if any one of these legs is not done, then you can imagine that this treatment regimen falls down. So let's just talk about that a little bit. Let's talk about monitoring blood glucose, why, when, what. So the first reason I think people should check their blood glucose is really to educate themselves. So I like to tell people, particularly if they're not necessarily on insulin, that they could just check their glucose twice a day. And there's two different ways in which to do that. One is to check at bedtime and in the fasting state, that is to say, after one has not eaten for several hours, at least 8 hours. It kind of tells you what happens to your blood glucose when you're not eating. And then another time, another pair of blood glucose just to check is before a meal and 2 hours after a meal. It sort of tells you what happens when you do eat. And then, of course, the other major reason is particularly for patients who are intensively managing their diabetes because they're on insulin multiple times a day, is to adjust the doses of insulin so that to get the most efficacy in terms of getting the blood glucose normal, but also from the standpoint of safety, so as to not give too much insulin and have a low blood glucose. And so how often one should check blood glucose is really depends on the medical regimen. If somebody's just on pills, I think we typically recommend that you check on average once a day. But if no treatment decision is being made on any one individual blood glucose level, what I really think in that circumstance is that it's more for one's own education. But obviously, if one is on multiple injections of insulin, then checking the blood glucose 4 times a day, 5 times a day is advisable. And so good numbers for blood glucose in the fasting state are 80 to 130. And in general, we tell people to check before their meals. And during the day, 100 to 160 would be considered a very good glucose control. So to monitor blood glucose, we have different options. One is a typical glucometer and a finger stick, which probably many of you know about. It involves pricking your finger, occasionally other parts of the body, but that's not done that commonly. And it's measuring the glucose in the blood. The other way, which I'm sure people have heard about, are to use devices called continuous glucose monitors. These are devices that sit on top of your skin, typically either the back of the arm or on the abdomen. And they are measuring glucose in the fluid that's sort of around the fat just beneath your skin. It turns out that this closely mirrors blood glucose with a delay of about 5 or 10 minutes. And there are devices now that measure this glucose quite accurately to within 10% of the blood glucose level. And so I just want to say a word about these continuous glucose monitors. I think I cannot say that they're new anymore. A few years ago that was true. But they allow for really a detailed review of data. And I think they contribute to shared decision-making between providers and patients. The other big thing is because the glucose is being measured by these continuous glucose monitors every 5 minutes, you can get profiles as if you're seeing here on the right-hand side, where the y-axis is the blood glucose, on the x-axis is the time of day. And you can see in this individual that on average, the blood glucoses are running a little higher than 180 between midnight and say 3 p.m. And then around 3 p.m., the blood glucoses seem to fall. And that might be right around the time where there's an increased risk of low blood glucoses, as indicated by the spread of the data, here approaching a glucose level of 70. And so these continuous glucose monitors can alarm if the blood glucose is going low and help the patient to take action so as to prevent that from occurring. So let's just talk a little bit about medications. There are pills or injections for non-insulin medicines, and they have different modes of actions. So some improve resistance to insulin. That would be a medication, for example, like metformin. Some actually improve the beta cell's ability to make insulin and secrete insulin. Those would be medicines called sulfonylureas, things like Amaryl or glipizide. Amaryl is also called glimepiride. The newer class of medicines that you may have heard of, things like Ozempic, Trulicity, those are all injectable medicines. They also improve the beta cell's capacity to make insulin. And they, in addition to that, they also reduce people's appetite. And there are some medicines that one of What I will say is that some of these newer medications, the so-called flozins, they're the ones that make you excrete more glucose, and the glutides, those are the ones that are injectable and reduce people's appetite and improve the ability of the beta cell to secrete insulin. They should be used with a little bit of caution in people with transplant. They have not been extensively studied in that setting. That's not to say that we don't use particularly the glutides, but the flozins, because they could cause dehydration, we are very cautious with. And then there are insulin-based regimens, and I'm just giving you examples of 3 different types of regimens here. On the y-axis is the insulin effect, and on the x-axis would be time of day, with breakfast, lunch, and supper being matched, as well as bedtime. And what one typical regimen is to give a long-acting insulin once a day, that's shown in green here on the panel A, and then give short-acting insulin analogs with every single meal at breakfast, lunch, and dinner. Sometimes such intensive types of regimens are either not required or undesirable for a variety of reasons. And for that, we have what we call intermediate acting insulins, where people can usually get away with just taking 2 shots of insulin at breakfast and supper. And it does that because the insulin has a peak effect, this intermediate acting insulin in brown that you can see here, as opposed to the long acting insulins, which don't really have a big peak effect. And then there are, of course, insulin pumps. That's shown in panel C, where a pump is actually delivering a short-acting insulin continuously, and that's called the basal infusion. And then every time one eats, the pump can be instructed, essentially, to give a bolus of insulin, because you can remember from the first slide I showed you on insulin action, that's what a pancreas would do. It would secrete a big surge of insulin at the time of a meal. So just to give you a sense of what these short-acting insulins and long-acting insulins, how long they really act. So on the y-axis here on the left panel for short-acting insulins is the serum level of insulin, and on the x-axis is the time going from 0 out to 480 minutes. We have regular insulin, which has been around for a long time, regular human insulin, and you can see that it has a duration of action that extends into the realm of about 6 hours or so. And it has a peak action, but it's not so pronounced. The more commonly used shorter acting insulins now are the insulin analogs. Those are shown in blue here, light blue and dark blue. And you can see that there is a pronounced peak effect that occurs usually somewhere around 90 minutes. And the duration of action is really on the order of about 4 hours or so. And we typically use these more commonly when we have a complicated insulin regimen, because there isn't such a prominent tail effect past 4 hours, and it mimics more closely what a normal pancreas would do in terms of the big surge of insulin after a meal. The intermediate or long-acting insulins are shown here on the right, and just to give you a sense that many of these that you've heard of, so Detamir is Levemir, Glargine is Lantus or Basaglar, Degludec is Tresiba. They all have this action, prolonged action extending to 20, 24 hours or even more in some cases. NPH insulin, which is just regular insulin with some modifications, you can see actually does have a very pronounced peak effect at 4 to 6 hours, and it goes away in about 12 to 16 hours. And it turns out that we like to use this insulin in people who have only steroid-induced hyperglycemia, because it matches the effect of prednisone very well. So just some cautions about treatments. So low blood glucose is glucose less than 70. Below a glucose of 55, brain function may be compromised, and the risk for seizures, coma, and death increases. So there are certain medications that put people at risk for a low blood glucose, and they include insulin or the sulfonylureas that I mentioned, glimepiride and glipizide. And the basic reason is that once you give a shot of insulin, or once you take this pill and it starts to have its effect to make the pancreas secrete more insulin, you can't take it back. So you can imagine if somebody took a dose of insulin or a dose of glipizide and decided not to eat, for example, they could be at risk for low blood glucose. And then there are, of course, gastrointestinal side effects and dehydration that can occur with certain types of treatment. So I think that lifestyle regimens are very important, and visiting with a nutritionist to learn about diabetes and diet is absolutely critical. And there's very good evidence that repeated visits particularly in a diabetes education program, help to solidify and expand knowledge. And they also help improve self-management skills. And studies suggest better coping mechanisms amongst patients, including better blood glucose control. Exercise helps for the reasons that I mentioned before, but it should occur as allowed by the transplant team. And both strength and aerobic exercise have benefits with regards to improving blood glucose. For people whose blood glucoses are pretty darn well controlled, aerobic exercise can have a tendency to cause a low blood glucose if you're on the type of medicine that can cause a low blood glucose. And so you have to be cautious about that. Yeah, as I suspected, I finished in about 30 minutes. So diabetes occurs when there's an absolute or relative deficiency of insulin. After transplant, steroids and calcineurin inhibitors in particular predispose to diabetes. And dedicated testing for diabetes is strongly encouraged given the high prevalence that I mentioned. Treatment of diabetes is necessary to prevent those complications that I mentioned, short, intermediate, and long-term. And there are many different treatment modalities available. And I think that the new tools that have made monitoring glucose easier, particularly the continuous glucose monitors, really are changing the game with regards to the management of diabetes. So that's all I had. So I'm happy to take questions.
We do have a few questions in here. I can just go through them all and share them with you. The first one was, does mycophenolate cause some level of hyperglycemia?
No, typically we don't think of mycophenolate mofetil as being one of the causative agents for diabetes.
What is the likelihood that steroid-induced diabetes goes away if you're able to stop prednisone?
That's a good question. I think if somebody does not have pre-existing diabetes prior to transplant, and their diabetes has occurred only in the setting of prednisone, then I think there's a good likelihood that it could go away. The only thing to remember is that oftentimes there are other immunosuppressants that people take, such as tacrolimus, that do predispose to diabetes, that are essentially a new variable in the equation. So for some people it goes away and some people it does not.
Okay. If I'm able to get off prednisone, or at least to a low 5 milligram dose, does or will diabetes go away?
Yeah, I think I see a couple questions all in this realm here. Yeah, I think if one doesn't have diabetes prior to transplant, there's a good likelihood that the diabetes will go away. With this caveat to remember that if you're also on another agent that can cause diabetes, or I won't say cause diabetes, but can predispose to diabetes, then it may not go away. One would certainly expect it to become much, much easier to manage. And certainly we all have patients that needed insulin even for their steroid-induced diabetes. And once the steroid dose was reduced, we were able to stop insulin and sometimes stop all treatment.
The other one that kind of relates to that is, how long does steroid-induced diabetes take to go away after stopping prednisone?
Well, the effect of prednisone is, 16 hours. So if the prednisone is stopped, then the diabetes should go away within 2-3 days, really.
Okay. And I think you had this question already. Can mycophenolate cause diabetes or hyperglycemia?
Correct. Yeah. In general, we think that it is not a major contributor.
Okay. Is the mechanism of transplant-related diabetes one of insulin resistance, or is there another mechanism at play?
Yeah, it's a good question. So let me answer it this way. Nobody gets diabetes mellitus if their pancreas can make enough insulin. But enough insulin is determined by the state of insulin resistance. So there are lots of people that are on steroids and they don't develop diabetes. And that's just because it's not that the steroids don't have this effect of creating insulin resistance that I mentioned before. They do. It's those individuals' pancreas is able to respond to that stress and secrete enough insulin to keep the blood glucose normal. So insulin resistance can be a major contributor to the hyperglycemia. It can certainly make it a lot worse. But in the end, it's not the reason for the person to develop diabetes.
Okay. I think you may have answered this one in your presentation, but is there any way to counteract the effects of prednisone to prevent getting diabetes? For example, diet, exercise, etc.
I don't. Let me think. Diet and exercise and lifestyle regimens can certainly help because they'll help what the body is being exposed to or how many calories the body is burning. But if there is a sort of fundamental defect in how much insulin the beta cells can make, which is heavily governed by your genetic background. So type 2 diabetes, for example, is very heritable. And for example, if you have two parents with type 2 diabetes, your chance of developing type 2 diabetes is extremely high. But if you don't have parents with diabetes, your likelihood is relatively low. And so, I guess what I'm trying to say here is sometimes it happens not because of anything that one did do or did not do. It just happens to be the combination of one's genetic background, the prednisone, all of that together. And you won't find a diabetes doctor that discourages diet and exercise. And they will all certainly help make it easier to control the diabetes. But I'm not sure that one could prevent it.
Okay. What impact does sugary blood have on a transplant patient who has complications with continuous stenosis in the arteries that are frequently closed every 6 months, even with 2 stents, and that become clogged with blood clots? The patient is diabetic and is on Trulicity 1.5 milligrams.
I think that, without knowing the details, it's hard to say particularly, but depending on how long the diabetes has been ongoing, this could predispose to typical cardiovascular disease. To the extent that dehydration can make one more likely to have a blood clot, this will exacerbate the situation. So I think the major issue, assuming there's no blood clotting disorder, is that the blood glucoses are contributing. If they're high, they're contributing to dehydration, which will be problematic. But the mechanism of these stenoses is typically due to what is happening to the blood vessel wall lining. And blood glucoses alone are not the contributor to that. But I would say if there's hyperglycemia, it's certainly not going to help.
Okay. Are there any oral medications that can be used to treat diabetes post-transplant, or is insulin the only treatment?
Yeah, that's a good question. I think that medications like metformin, if the kidney function and liver function is okay, would be reasonable to use. Medicines like that I mentioned, like glipizide and glimepiride, again, if the kidney function is okay, are okay to use. That second group of medicines, they are associated with low blood glucoses, so there has to be some caution, particularly if there's some kidney damage. And we avoid them if the kidney function is worsened substantially. Some of the newer medicines we're reluctant to use because of some of the reasons I mentioned. So, for example, things like empagliflozin, which is called Jardiance, or Invokana, which is called canagliflozin, they cause you to pee more glucose. Well, they're also associated with a clear increased risk for genitourinary infections. So in somebody who's immunocompromised, there's a reluctance to use that type of medicine. For people who already have some kidney dysfunction, also we wouldn't want to make somebody dehydrated, as those medicines sometimes can do. The injectable medicines that are popular these days because of their weight loss effect, so things like Ozempic, Trulicity, I'm sure people have seen ads for those. Those also we are cautious with because there's not that much data. They reduce people's appetite. Some people have nausea. They get dehydrated. It might affect their kidney function. So I think that medicine we would use if, the kidney function was not as worrisome. And so I think those are really the main options. There are medicines like sitagliptin and saxagliptin. They're pretty modest in their effect. And I think most people feel comfortable using them in the transplant setting. There's one that is not affected by kidney function, so we can use it at that time. So I guess the short answer is yes, there are oral medications to use, and insulin is not the only treatment. Sorry, I went on for a little bit there.
That's okay. What effect does Trulicity have on transplant recipients and normal people in the short and long term?
I guess I'm assuming that this is not a question regarding the meaning the graft function. And I would say there's probably very little long-term actual information about this. But as long as somebody's pancreas is functioning, and as long as their kidney function is not concerning, I don't see any problems short and long term, if I'm thinking about this correctly. But the only question is, will it work? They don't always work.
Okay. Please explain again of why an A1C value may not be as correct following a kidney transplant.
Really, any situation, if the red blood cell turnover, so if somebody has anemia, and let's say, so let's take the kidney transplant situation. So even before kidney transplant, in those people who have renal failure, already there is a change in the dynamics of red blood cell production and red blood cell destruction. And so even in that setting, before transplant, the A1C is not fully reliable. When I mean not reliable, I don't mean like, like the A1C is actually 6.5, but it's reading 9%. It's not off by that much, but it is off by a percentage point or so. And so it won't be as accurate in monitoring what the actual level of blood glucoses are. But certainly it could be used for the trend, and one should be cautious about using it for diagnosis. But for example, if we say the diagnostic cutoff is 6.5% and somebody's A1C is 9 or 10, well, that person has diabetes. We don't really have concern. But let's say their level comes back at 6 or 7, then we might want to do some other tests. We would want to look at their fasting plasma glucose. Is that consistent with what we're seeing? So things like that.
Okay. What milligram daily levels of prednisone or tacrolimus may cause metabolic issues that you described?
Sure. Really, it's different in anybody and in everybody. In general, a level of 4 milligrams of prednisone or less is considered normal physiologic replacement. Like that's what a normal adrenal gland would make in terms of its steroids. So above that level is, supra-physiologic. I would say that most people that develop steroid-induced diabetes, it doesn't happen with a dose of just 5 or 10. It's usually happening with more than that. But every now and then there's a person who has diabetes, hyperglycemia, let's call it, with a prednisone dose of 10 or 15, but doesn't have it with when the dose comes down to less than 5. For tacrolimus, I don't have as good a sense. Certainly when the tacrolimus levels are high, and I know that the levels have to be checked and the dose adjusted frequently, we have seen situations when the levels are uncomfortably high, let's call it, that the blood glucose levels seem to get worse. And that's because, like I said, these medicines are toxic. But I can't tell you a dose, because the dose really is not the issue, it's the level in the blood.
Okay. This one had a score of 218 on a finger stick, 224 on Dexcom. Who's right?
Well, the question is not who's right. The question is what decision has to be made based on this level. And to the extent that this difference, which is, I can do my math correctly, only in the range of about a 3% difference, is not likely to affect a treatment decision substantially. And so this error would not cause. But in general, if the glucometer is calibrated, then we believe the finger stick, because it's actually measuring. Well, let me make 2 points. As long as the glucometer is calibrated and somebody doesn't have a problem with circulation in their fingertips, then we believe the finger stick, because it's measuring blood glucose. But this is not the type of difference that we worry about. And this has been studied, by the way. In general, this 10% error that I described to you does not most of the time affect treatment decisions. Having said that, there are people who say that their Dexcom or their Libre is routinely 10 to 20 milligram per deciliter off from their finger stick blood glucose. And in those situations, we have to make decisions about whether it would affect the treatment.
Okay. What are the pros and cons of using insulin? I don't know if you answered that before.
No, I don't think I really did. So the cons are insulin, if not matched well to activity and food, can cause a low blood glucose, and low blood glucoses are very uncomfortable for one thing, but can cause major symptoms and even death if severe. Obviously, we take all precautions to avoid that. Insulin treatment is associated with weight gain, and that depends on what the goals of treatment are. But how should I put this? Some of the weight gain is because people actually were losing calories and lost weight because of the diabetes. But some of the weight gain is due to the fact that we cannot exactly match insulin perfectly, the way insulin treatment, the way a normal pancreas would match insulin. And so people may gain weight, even though maybe their caloric intake is not that high. And I would say those are the major cons. The pros are that there's no ceiling to the effect of insulin. So all the other medicines that we use for treating diabetes, type 2 diabetes, they all have a ceiling. They have a treatment effect. We kind of know that we can get this much A1C reduction with them. With insulin, that's not the case. If somebody needs more insulin, we can give more insulin. So it's effective in that sense. Typically, we can get blood glucoses under control quicker in certain settings. And particularly in people who have kidney issues, although we have to be cautious because it's relatively predictable what will happen with the insulin, we prefer to use it in people who have some degree of kidney failure, because we're not worried about a drug hanging around for an unpredictable amount of time because it's not being excreted by the kidneys. So I think those are the major pros and cons. There is some people who say with long-term insulin treatment, you might be affecting the cardiovascular system. I think what we definitely know is that long-term poor blood glucose control is bad for the cardiovascular system and is bad for the eyes and the kidneys and the nerves. So that's not really a reason not to take insulin.
Okay. Are magnesium supplements or foods effective in reducing blood glucose? And if so, which ones?
No, I wouldn't say that. I think that they could be contributing factors for the blood glucose being elevated, but I don't think taking magnesium supplement is going to be substantially effective.
Okay. If A1C is not accurate to diagnose diabetes, then how to figure it out?
Yeah, so I think I referred to this,
Mhm.
just have to interpret the level. If it's close to the diagnostic threshold, then checking a fasting plasma glucose or doing an oral glucose tolerance test. Some of you are familiar with this test. You have to come into the lab. They give you this 75-gram sugary, nasty tasting solution that you have to drink, and they measure the blood glucose 2 hours later. Those would be the ways.
Okay. I'm a controlled diabetic from treatment in 1997, not on dialysis yet. What are my chances, I think it's of becoming active again? It says are becoming active again.
Yeah, I guess I'm not exactly sure what the question means.
Okay. So
yeah.
if you ask that question, maybe you can restate it. Be a
Yeah.
little bit clearer for us.
Yeah.
After transplant, diabetes will develop for sure?
No. Like I said, the rates of developing transplant after diabetes are 10 to 20% in the setting of kidney transplant. For somebody who didn't have diabetes before, 20 to 40% for other solid transplant. So,
okay. Inflammation in the throat is an indicator of something?
Yeah, that's a difficult question to answer. It could be an indication of many, many different things.
Okay. What can you do to bring down high glucose? I know fruit juice can raise low glucose, but after dinner I could go up to 350. Bear in mind, I'm 9-year heart transplant who takes Prograf and my fork twice a day. And even with good portion size meals, this is where I am.
Well, I think that if the blood glucoses are routinely going that high, that's concerning for diabetes. I wouldn't discount the effect of exercise if one is able to, for example, go for a walk. Many people do that. They know, for example, that if they have this type of meal, their blood glucose doesn't go up that much. But if they have this other type of meal, their blood glucose goes up by 100 points more. And they also know that if they go for a 20-minute, 30-minute walk afterward, the blood glucose comes down much more quickly. So that's a very typical thing. Obviously, if this is happening after every single meal, then really the question is are medications required? I guess I don't see if a medication, I'm not familiar with myphoric. I'm not sure what that is.
Okay.
I might, while I'm talking, I'll Google it.
What class of drugs is Farxiga? Any cautions when taking it? I'm on metformin as well, 2 times a day.
Myfortic is mycophenolic acid. Okay. Farxiga is in the class of medications called sodium glucose cotransporter inhibitors, or SGLT2 inhibitors. They're the ones that make you pee glucose. And so the caution is just to remember that there is a risk of genitourinary infections and dehydration. If you're not having that, then fantastic, no problem. But the other thing to remember that I didn't say about this class of medicines is that this class of medicines is associated with this unusual situation of developing diabetic ketoacidosis when the glucoses are not that high. I don't know how technical to get here, but basically if you don't make that much insulin, or if your insulin levels drop a lot, your body starts to develop ketones. That's a normal response to starvation. Anybody who starves for 2, 3, 4 days, they make something called ketone bodies that shunts energy away from the liver into the brain and muscle. Those are acids, and they're dangerous. And for that reason, acid builds up in the body. So these medicines are associated with that, particularly in the setting of some other stress. So the big thing that people need to remember is that if they're on a medicine like Farxiga or Invokana or Jardiance, and you're not going to eat for some reason, like you're going to have surgery, or you're feeling sick and your oral intake is going down and down and down, then you're at a risk for developing this. So it's actually an FDA guidance that these medicines be stopped 3 to 4 days prior to any scheduled surgery. And metformin has to be stopped the day of surgery as well.
I'm going to take these other two and then we'll have to wrap it up. Can a patient with diabetes eat desserts daily as long as they keep their blood sugar levels more or less in control with medications such as Trulicity?
Sure, if the numbers are good and the blood glucose is good and the weight is not going up in a way that is worrisome to your medical team, then of course, but if the blood glucoses are not good, then, one has to decide what is important.
Okay. And would you be able to elaborate on how poor hand or finger circulation negatively impacts finger stick readings?
Sure. So let's say you have poor circulation to the fingertips, but those tissues still need to get the nutrients and primarily the oxygen, and so they have to work a little bit harder to do that. And oftentimes, because of this poor circulation and because of this effect on nutrient extraction, the blood glucose reads low. And, to the extent that you don't, if you check your finger stick and it reads 50 and you feel totally fine, then maybe the problem is the finger and not the blood glucose.
Okay. Thank you for answering all those questions, for giving us a lot of wonderful information to consider. We appreciate you sharing that with us. To close out this year's conference, I'm going to post a video from Marin.
Thank you for joining us today for Trio Maryland's second virtual transplant conference. We hope it was educational and provided the information you needed to lead a healthy transplant life. I would like to express our gratitude to the Trio Maryland Board of Directors, Ashton Conference Planning Professionals, and also our partners, the Living Legacy Foundation of Maryland, Johns Hopkins Hospital, and the University of Maryland Medical Center. I'd like to thank our speakers for sharing their expertise with us. And a thank you to our sponsors that continue to support Trio Maryland and all of our educational efforts. Trio National, Veloxis, Anatomy Gift Registry, Peak Relief, and the National Kidney Foundation of Maryland and Delaware. Don't forget to check out our sponsors' websites for details and information. All sessions have been recorded and will be available to view on the Trio Maryland YouTube channel. And our email notice will be sent out to you when it is available. Check out our website at www.triomaryland.org to view our calendar for upcoming speakers. Follow us and like us on Facebook and Twitter. I post current information daily, so don't miss out. Check out our YouTube channel for past presentations, and we want to thank you all again, and thanks for starting your day with us.
Thank you again to everyone who joined us today. You can check out the website, join the organization, and look at some of their upcoming events and courses, and also donate to support efforts like these. Have a great rest of your weekend.